everyone. Thank you, Dr. Bagaria, for inviting me on this stage. It is indeed a privilege to be in the same room as all you esteemed surgeons. I am actually the odd doctor out in this particular domain. So I am, well, Dr. Darshan Shah, but an engineering doctor. So to begin with, let me give you a perspective of why I'm standing in front of you today, or why it is relevant that I'm speaking to you. I specialize in biomechanics and orthopedics, and I started my journey as a mechanical engineer from IIT Bombay. But I soon did a doctorate, a PhD in bioengineering from Imperial College. And most recently, I worked as a biomechanist at the University Hospital in Leuven, Belgium, where I worked at this Institute for Orthopedic Research and Training, which was affiliated to the Faculty of Anatomy, the Division of Orthopedics, and the Engineering faculty of the university. So I was doing translational orthopedic research. And now I'm a faculty at IIT Bombay, once again pursuing research, translational research in orthopedic biomechanics. So the research in the past decade that I have really pursued is on upper and lower limb joints. And most importantly, it has always been in collaboration with orthopedic surgeons and the medical industry. Once again, as a mechanical engineer, I like to see things, I like to see things move. So in the organizational hierarchy of the human body, I like to work on the organ and the organ system, so mainly the macroscopic joint biomechanics, if you may. And I like to classify the research that I do into three main modalities: the in vivo, or the human research that most of you surgeons speak about, the in vitro, or artificial or cadaveric research that quite a few research enthusiasts pursue, and in silico or computational research that we've seen quite a few talks today about. So in vivo research, human research, is usually survey-based analytics. For example, functional rehabilitation of partial hand amputees, a project that I had done during my postdoc. You have these standard gait lab, motion capture related studies being done for physiotherapy or post-operative rehabilitation. And then you come to device development, developing implants, surgical navigation, or non-surgical diagnostics, which is all part of the in vivo realm. Jumping to the computational or the in silico research, you have basic design analysis. So this is something I did at IIT Bombay, where we patented a modular total knee arthroplasty implant. You have computational modeling. So this is the buzzword with surgeons who are actually interested in biomechanical research. Let's perform an FEA analysis, the finite element analysis. It's basically looking at the localized tissue deformations once you have your implant or a surgical protocol in. And then on a more macroscopic scale, you have your rigid body modeling. And of course, you have a lot of artificial algorithm-based imaging processing projects, like the characterization of the intramedullary cavity of the tibia that I had done for an amputation implant. Sorry. But let me move on to the in vitro research. This is what I am really excited about. So there are static studies that are mainly dissection based, where we did a tendon pathway study for musculoskeletal modeling. But it can also be a bit more than that, a bit more engineering, like this dorsal hand trauma due to blunt impact. This is a cadaver testing that we had done back at Imperial College. And moving a step further, we can go from static to dynamic. We can have passive dynamic studies where you have a manual actuation, or you basically move the joint in a simplistic fashion using dead weights or using springs, but essentially to address an orthopedic problem. So here, for example, we've created this device that can move the wrist. And we use this device inside a 4D CT scanner to actually follow or monitor the carpal kinematics following scapholunate lesions and reconstructions for that pathology. More importantly, as an engineer, I've worked on these active dynamic simulators, which essentially are physiological simulators. So they not only replicate the motion, but also the loading condition of the joint, just as you would have in a natural joint. but in cadaveric specimens. So this, for example, is a foot and ankle simulator that I was involved in developing at the IORT. And we use this to understand some native joint biomechanics, which we wouldn't be able to perform in vivo because it would be quite invasive. So for example, we tested the role of tibialis posterior tendon and medial ligaments in stabilizing the medial foot arch using these dynamic activities on the simulator, which could also replicate the loading fashion of your foot during a gait cycle. Right? And we published this in a clinically relevant journal, if you see, Foot and Ankle Surgery. Again, this was a simulator that I myself built from scratch. This is a wrist simulator which can be used to objectively compare surgical procedures, wherein you have a lot of subjectivity going on with different, for example, we compared different post-trapeziectomy surgeries for carpometacarpal osteoarthritis, and we could objectively compare which surgery is better on what parameters. So once again, it was an editor's choice paper in a clinical journal. The knee simulator that I worked on, very easy to imagine how we use this simulator to predict post-operative biomechanical outcomes like coronal laxity after different alignment techniques or different implant constraints post-TKA. And more importantly, we have also used these simulators for orthopedic training and education, where we could show that when we compared fresh residents to really trained surgeons, the biomechanical outcomes, post-operative outcomes, had a correlation to the expertise of the surgeon based on the outcomes we get from the simulator. And once again, this was received well at the Orthopaedic Research Society, and we received a clinical award for this. So this seemingly biomechanical research has a lot of clinically relevant objectives and outcomes to it, which is what I wanted to share with you today. So of course, each of these modalities has its own pros and cons. For example, the computational modality has certain assumptions. The in vivo modality, of course, you face from a lot of ethical challenges, and the in vitro modality, the cadaveric testing, has a lot of maintenance and logistical challenges that you have to overcome. So essentially, it brings me to this harmonization of these three modalities that one needs to establish whatever research protocol related to surgery one is doing. So this is what I call the golden triangle. And to simply give you an example, for the gait simulator, for example, we perform some human kinematics in vivo and computationally calculate muscle forces, which we put in the in vitro simulator, which eventually gives you outcomes required for post-operative rehabilitation, for example, so in vivo. So again, at IIT Bombay, I lead this lab called Biome, which stands for Research in Biomechanics, Orthopaedics, and Musculoskeletal. Yes, I'm almost done. Musculoskeletal engineering. And while we have really exciting projects going on all three modalities, the reason why I'm here today is because the translational research in orthopedics is something where I want the problem statements to come from the surgeons, the people who are making a difference. And we would like to be facilitators there to help you. So yeah, my message here would be to start collaborating and making a difference together. Thank you.